Good evening, everyone, and a warm welcome back to day 3 of Oncology Pharmacy Conclave 2025, an immersive event that focuses on cutting edge oncology therapeutics, evidence based clinical decision making, and collaborative multidisciplinary strategies. This conclave brings together a distinguished faculty of medical oncologists, clinical pharmacists, dietitians, and yoga physicians. And this is Rachana. I'm very excited to host today's session. So, without any ado, let's begin today's first session for the evening titled Optimizing Safety in Oncology Strategies for Medication Management. Here, we try to understand improving the patient safety in cancer care by using better methods to prescribe, prepare, administer, and monitor oncology medications. So, once again, I would like to introduce the speaker for the session, Dr. Pravalika Utukuru, a family professional who has completed her residency in oncology at JSS Mysuru and has served as the head of the Department of Clinical Pharmacology. She is well known for her expertise in oncology pharmacy, protocol development, and training healthcare teams in safe medication practices. With extensive experience across clinical practice, academic leadership, and oncology residency mentorship, she brings deep insight into safe chemotherapy standards and protect patients, professionals, and the environment. So before we begin, I would like to inform everyone that we'll have a Q&A after this session. So please keep your questions ready and the virtual stage is all yours, ma'am. Please join me in welcoming Dr. Pravalika Utukuru.
Hello, Rachna.
Yes, ma'am.
Yes, ma'am. Krupa ma'am will be taking first, okay?
Oh, okay, ma'am.
She's just called. She'll start off.
Okay. Shall I introduce her, ma'am?
Yeah, you can introduce her.
Okay. So our today's first session it will be titled Next Gen Therapies Exploring Immunotherapy, CAR-T and Future Frontiers, where we learn about newest medical treatments that use the immune system like immunotherapy and CAR-T cell therapy and exploring upcoming advanced approaches that may shape the future of healthcare. And I would be honored to invite our speaker for this session, Dr. Kripa Bajaj. Dr. Kripa is a senior consultant medical oncologist at Omega Hospitals, Hyderabad. She is experienced in establishing an oncology department with exceptional success rates in CAR T cell therapy and bone marrow transplantation at KIMS Sunshine Hospitals, Hyderabad. As a director and head of the Department of Medical Oncology, Dr. Kripa has also gained rich experience in both solid and hematological malignancies as a consultant medical oncologist at Indo-American Cancer Hospital, Hyderabad. And it is truly honored to welcome you, ma'am.
Thank you so much, Rachna, for the kind introduction. So, I request someone to share my slides.
Ma'am, is it visible?
Yeah, it's visible. Can you please make it full screen?
Yes, ma'am, it's full screen now.
Right. So, CAR T cell therapy, immunotherapy, target therapy, these three, like chemotherapy is there from almost 3 to 4 decades of time in almost all cancers. But what is most recent and most established in management of oncology, which was not ever happened before, is one is CAR T cell therapy. Second is immunotherapy as well as target therapy. Chemotherapy in general will act on all fast proliferating cells, whereas immunotherapy will act on immune system. It will actually activate the immune system and it will make the immune system to act on the cancer cells to eradicate the cancer cells. Whereas target therapy act on specific protein to kill the cancer cells. What is CAR T cell therapy? Like why it has gained so much of importance, especially in hematological malignancies. So I'll just take a quick walkthrough with the CAR T cell therapy. I'll just importantly discuss regarding the refractory DLBCLs especially because these are the area where even DLBCL as well as the leukemias, these two areas are the areas where CAR T cell therapy has gained a significant importance. The reason why it has gained so much of importance in the short time is one of the reason is because it has previously, whenever any person got a refractory DLB cell, we take it as a death sentence. But now, with the advent of CAR T, if you see compared to leukemia, lymphomas, incidence is quite high. And out of 100, at least 20 to 30% lymphomas will have a refractoriness. It's very difficult for us to treat the lymphomas. So I just share some cases which I treated before so that it will be a real world experience to people like who are attending here. Can you please change to the next slide, please? So the case number one scenario is a 72 years male patient who is hypertensive diabetic, and he has a NHL DLB cell type active disease in the there in the both supra as well as infra diaphragmatic lymph nodes with a mild pleural effusion. Next slide. So usually elderly, we don't really give anthracycline basically because all our pharmacy people are there, pharmacologists are there. Saying that anthracycline based regimens we don't really use in elderly NHL. We try to give R mini chop. If not, we'll compromise on certain extent because with them the toxicity will be very detrimental. With the outcomes will be very detrimental with a significant mortality. Next slide. So the patient we gave RCOP instead of R-CHOP. The standard regimen in DLBCL is R-CHOP. We gave RCOP because patient unlikely, we thought he might not tolerate. The patient did well for 1.5 years, and later again he got a lymph nodes got noted, and later again RCP was given, partial response got noted, and again after 6 months again some mild treatment was given. Absolutely, there is no response. So predominantly, this is a refractory one. What is the next step you do? Next slide. So the outcomes with non-CAR T cell therapy for refractory DLBCLs, it is like dismal. Especially in patients who are refractory, we can't really give autologous stem cell transplantation, especially elderly, the autologous transplantation cannot be given. So the primary refractory, the outcomes are dismal. If you see here, 6.6 months, 5 months, this is the thing. The pooled analysis say it is only 6.3 months post 2 lines of treatment. Next slide. The pivotal trials leading to FDA approval are CAR T cell product, the Zuma 1, Zuma 5, Zuma 2, Juliet, Elara, Transcend trial, as well as in CLL also the Transcend trial is there. So this has shown a significant benefit. If you see 5 year survival is like cross 50%. The one which we thought only just 6.3 months. Now the FDA approval was accelerated because the percentage of survival got increased. The 5 year survival for Zuma 1, the first trial, the Axicell, has gone up to 59% for 1 year, and 5 year it is almost 42.3%. Whereas Zuma 5, it has shown almost 80% 3 year survival, which is like really significant. Next slide. So how would you rate the key clinical consideration while referring a patient of CAR T? The patient fitness is most important. The disease burden, what are the prior treatment and its response, the timing of the referral, and age. Next slide. So the patient who are especially refractory to the first-line therapy in 65 years or old, the high-grade lymphomas, the benefit of Axicell in older patients of particular interest because patients who would otherwise be considered ineligible for definitive therapy with HDT AST owing to the age may still qualify for CAR T, thus benefit from curative intent therapy. So these findings has confirmed age alone should not be the barrier for consideration of the CAR T cell therapy. The highest age recorded in CAR T cell therapy trial inclusions as well as the treatment is as high as 78 years old. So the indications are that does the patient have a disease and therapy history that meets adaptive cells data? Does the patient meet the criteria for clinical trial? The kinetics of disease progression means like would the patient be eligible to go through the leukapheresis without immediate use of steroids or chemotherapy and remain stable until T cell infusion, that's a 3 to 4 weeks of time. Does the patient need alternative therapy prior to CAR T cell infusion consideration? Immediate prior therapy? How would this affect the ability to successfully manufacture the CAR T cells? Concomitant immunosuppressive therapy, can this be safely stopped prior to collection? The active infection also has to be ruled out because if patient experience CRS, the patient who are having active infection might land in the significant issues. The non-disease comorbidities, does the patient have organ dysfunction? Because if the dysfunction is that they cannot tolerate the toxicities of CAR T-cell therapy, the like CRS, ICANS and all. Next slide. So this is a patient eligibility criteria, what we do check. So why I'm stressing so much is that the autologous stem cell transplantation in lymphomas cannot be offered even to the patients who are 60 plus, because we expect significant toxicities for autologous stem cell transplantation. But for CAR T-cell therapy, that's not a criteria. Age is absolutely not a criteria. The available CAR T-cell therapies may be appropriate for patients with advanced disease with a life expectancy more than 6 weeks. Remember this, with a good, decent performance status, with a preserved organ status, like especially creatine, because appropriate dose reduction of therapy, like a primarily fludarabine, can happen if the creatine clearance is not maintained. The ability to tolerate lymphodepleting CIT and CAR T-cell therapy process, potential toxicities, all these are very important. So there should not be any active infection. The sufficient social control should be there. The caregiver support should be there. Multiple travel and housing support should be there. Next slide. So usually patients whoever got a large disease burden. So if you see here, there is a inguinal lymphadenopathy is there here in the left side. So that got cured entirely. Everything got cured. Nothing is there post CAR T-cell infusion, because the person who progressed on 3 lines of treatment with the disease is there, that might progress if not treated well. But with CAR T infusion, everything got cleared. He got cured of the disease. Next slide. And again, the case two scenario, this is also elderly one who got treated with R-CHOP. This one, I was in the training regarding this case, like when this case got treated. So I'm really fond to share this. I treated him in 2022, and later there was a relapse in the pleura. Everywhere the relapse was there. At the time, the CAR T trials were going on, and we suggested him post 6 RD also not much difference is there. So there is a progression is there. So that's why I pushed him to the CAR T cell therapy. Next slide. What will be the approach? The double expressor lymphomas, the outcomes are really bad. The double hits and double hits are notorious for the outcomes. Next slide. Next slide. So the salient features are in the dual expression MYC and BCL2 proteins not related to underlying chromosomal rearrangements. They are termed double expressor. Double expressors, double hit. These two are the lymphomas which are like very aggressive. The high-grade B-cell lymphomas with the dual arrangements, they are called as double hit lymphomas and triple hit lymphomas. So these are more likely to relapse after the standard chemoimmunotherapy. And moreover, the relapses in this subset of patients tend to be very early, within just 12 months of time. Consequently, there is an urgent need to identify effective treatments for these subgroups. Next slide. The double hit and double expressor lymphomas, a multi-center analysis of survival outcomes with CD19 CAR T cell therapy. Next slide. It has shown DHLs, DLs, the double expressor, double hit lymphomas are also significantly included here. Significant percentage is there here. Next slide. So the outcomes of double hit and double hit lymphomas are better with the advent of CAR T. PFS after CAR T exposure is much better. It is not even reachable. Actually, they are doing the flat line indicates that they are doing really well. Next slide. The one which we thought they'll not do well with relapse within just 12 months of time, they're doing really well. So case scenario 3, 30 years male with a CMYC BCL2 on IHC, treated with 3 cycles of R-CHOP, interim PET suggestion of progression of disease. They received polar RCHP, the stable disease, primary refractory disease got noted. Next slide. How do you approach a primary refractory DLBCL? Next slide. The survival with axicaptagen psilocin large B-cell lymphoma, the analysis shows that significantly longer event-free survival got noted with the standard of care. Next slide. Indian scenario, these are not available, but the same replicas are there by the two companies, Immunoact as well as Immunil companies. We are having a hands-on data with this. It's really amazing to see some of the Indian companies producing such a high-quality product, and the outcomes are as good as the foreign companies. So in Zuma 7, 73.5% of the patients with disease refractory at the first line, they did really well. Next slide. The median OS was not reached in the Axicel group and was 31.1 months in standard group. The 74% of patients with primary tract disease and high-risk features got noted, and the median follow-up of 47.2 months Axicel as second-line treatment for patients with the early relapsed or refractory B-cell lymphoma. They result in significant longer OS than the standard care. Next slide. So if you see, all subgroups are erring towards the Axicel. It suggests Axicel treatment is better. Next slide. The salvage and bridging therapy, the community and academic coordination of the care is very important. The goals of salvage therapy is to stabilize the disease. It requires washout period before apheresis. Salvage therapy may be recommended during the time between referral and consult and apheresis for patients with a rapidly proliferating disease. Bridging therapy may be recommended during time between apheresis and lymphodepletion. The goals of bridging therapy: reduce tumor burden, palliative symptoms, and stabilize disease and quality of life, and to maintain functional reserve during manufacturing period. Maintain the frequent communication with patient, primary oncologist, and manufacturer. It choose least toxic therapy if possible and allow hematological recovery prior to LDC. It consider avoiding immunosuppressive therapy, checkpoint inhibitors, blinatumomab. Communicate when to stop salvage or bridging before apheresis. Next slide. CAR T-cell therapy best referral practices. CAR T-cell therapy is incorporated into the program in different ways. Transplant model. Patients are referred to transplant or cell therapist for consideration. Either way, refer early to optimize patient outcomes. Patients with a lower volume disease and who are less heavily treated will do well. So the performance status plays a very important role, and the patient baseline status regard pertaining to the performance status, infection status, all these plays are really important. So CAR T-cell therapy best referral practice is important. If someone feels that with basic R-CHOP they are not doing well, if it is not a tertiary care center, kindly refer the patient to the higher center for the better management. Next slide. Thank you. I just want to add, we have a hands-on experience with Indian CAR-Ts for the three patients. Three patients did tremendously well. I'm the person who did first CAR-T cell therapy even in the autoimmune disorders, that's the SLE. So to say that in CAR-T cell therapy will act on the blood cancers like leukemias, lymphomas, as well as multiple myeloma. Apart from this, there is one more entity, the autoimmune disorders like SLE, systemic sclerosis, myositis, Sjogren syndrome, where CAR T cell therapy patients will do really well. They no need to, the immunity will be depleted, the B cells will be depleted, they do really well. So, the patients whom you feel they're not responding to the regular treatment, the patient has to be referred to the tertiary care center for the better management. With this, I conclude my session. I'm happy to take any questions.
Thank you, ma'am, for accepting the invitation and having a good presentation. Ma'am, can you please highlight the role of clinical pharmacists because many are family students here? Like, how would you appreciate a clinical pharmacist in a healthcare team in oncology?
So, yes, especially in oncology, role of pharmacist, a clinical pharmacologist is significantly important. I don't know about the other branches. Pravalika is there with us, and we work together. We made a great team, and unfortunately, not unfortunately, fortunately, she got married and she moved out, and I also have had to change my place. Soon, we are planning to collaborate together further again as a great team for good oncological outcomes. So I'll just add my experience with Pravalika because not Pravalika, like with other clinical pharmacologists also, how they are important. Clinical pharmacologists are very important pertaining to the monitoring and supervising the dilutions as well as following the protocols because they are exceptionally specialized in that. Even they're better than the doctors pertaining to the pharmacy side and pharmacological aspects. It, adhering to the strict protocols is very important in oncology, especially that the dilutions, the durations, and the sequencing of the drugs matters a lot. And also the adverse reaction monitoring. How can we modulate the further treatment? Everything will be recorded well by the clinical pharmacologist, not us. And also, any mistake will be picked up very, very early by them than anybody else because the nurses and the trainees, the junior clinical pharmacologist all should be like supervised well for a good aggregation of the clinical care and also seamless execution of the clinical care. So, this branch is only just going to grow. I'm looking a lot of like a young and bubbling talent of clinical pharmacologists everywhere. And so this is only going to grow. The importance is only just going to grow. So, prior there was no awareness, but right now doctors are also appreciating it well. And clinical institutions which are thriving for clinical excellence, good outcomes, they're hiring good quality clinical pharmacologists. They're as important as doctors, I must say. And they're very important for executing a very good care. So only that can be possible with a good team of clinical pharmacologists and nurses. And I appreciate Pravalika for all her efforts. The CAR T-cell therapy is what we executed. There was a tremendous contribution of her in this, and all three are successful, quite successful with her help. So with this, I thank all the clinical pharmacologists, and I wish all the best to each and everyone. With this, I conclude the session.
Thank you, ma'am. If any doubts, I'll let you know. And guys, if you have any questions, you can ask us. We'll get clarified before this conference gets over in another 2 days. If you have any doubts, you can ask before ma'am logs out. Any doubts, guys? Ma'am, I think no doubts. If anything, we'll let you know, ma'am. Thank you, ma'am.
So thank you.
Thank you, ma'am. Thank you so much for sharing your experiences with us. And it was an informative and thoughtful session where we learned about novel CAR T cell therapeutic strategies. Thank you once again, ma'am. Uh, So we'll be moving on to our next session for the evening, titled Optimizing Safety in Oncology: Strategies for Medication Management, where we try to understand improving patient safety in cancer care by using better methods to prescribe, prepare, administer, and monitor oncology medications. So once again, I would like to welcome the speaker for this session, Dr. Pravalika Utukuru. So before we begin, I would like to inform everyone that we'll have a Q&A after the session. So please keep your questions ready and the virtual stage is all yours, ma'am. And join me in welcoming Dr. Pravalika. Ma'am, the stage is yours.
Yes. Guys, what ma'am have told, what ma'am have explained in the previous class, previous hour, that is exactly what has been performed in the hospital, the treatment for a patient of CAR T cell therapy. Now you will understand, I'll show you the ARCHO protocol with which DLBCL was treated to explain you this medication strategies, all these things. So you will better understand which treatment has failed, where the patient has progressed, and why they chose CAR T cell therapy. Okay, hope you'll understand. Hope you are all there. We want more interactive session. Like yesterday, everybody was very active. I would like to see same faces and same questions. I would like to see in the chat box, ma'am, we are there. Yes or no? With your yes, I'll start my class because no single question was asked in the previous session. So I want you all take pen and paper, keep ready with all the questions. I'll answer you. Okay. At least for your certificates, you listen. At least you will, I want you to go out today with few points. Okay. I'll start my class. Okay, guys. The topic is optimizing safety in oncology strategies for medication management. So the topic looks very sounding relevant to us. But before we start, I would like to ask you, what is this medication management? Can anybody answer me this? Come on, guys. Can anybody? What is medication management? Polypharmacy, how to manage, Harshada. Okay, next one. Any other definitions? Have you heard of something? I'll read out something. Tell me yes or no, okay? Right drug, right dose, right time. Have you heard of this? Somewhere, right? Yes, yes, yes. Very good. It includes everything from prescribing, dispensing to monitoring for effectiveness and side effects. It also involves a care team. What does a healthcare team contain? Who are there? Doctors, pharmacists, nurses, and oncology care team contains so many people, speech therapist, yoga therapist. Yesterday you have seen, right? It's all a team of healthcare professionals who come together in saving the life of a cancer patient. Okay? To keep therapy on track and to avoid errors. In oncology, the drugs are potent and toxic. So, what is very important? Medication management is very important. It's very critical to protect patients while we deliver effective treatments. Very good, guys. You have answered so well. All these includes medication management. Okay. First, being family students. How many of you are fourth years? Fourth year family students, irrespective of all this. Have you heard some subject called clinical pharmacy? Clinical pharmacy? Yes. What is the first chapter in clinical pharmacy? What is the first chapter? Keep thinking, okay? So, I would like to always tell this to students when I start my class. Learning new skills helps to break the cycle of doing same things over and over again and make your day-to-day work more interesting. This is absolutely applicable in a clinical setting. You know, now you say you heard of something called evidence-based medicine, precision medicine. Okay? Scope. Okay, very good. Next chapter. Something called as medication history interview. Okay. So, learning new skills. In a setting like hospital, when you work, you learn new skills. Every day you go, you do same job, desk job, come back. You get so much bored. In clinical pharmacy, if you consider every patient is new, and in oncology, every scenario is different. The same adverse effects, the severity is different. So every case is very interesting. It's very new. It'll help you to think more. So, how much ever pressure you have, work pressure you have, you work for more time, you learn something new. And end of the day, you will have a satisfaction working there, with the feedbacks that you get from your patients. That's why I always say your job should not be boring. It should be interesting, means you should learn something every day. And today, I'll teach you what's exactly happening in the hospital. Not just orally, just telling you what is drug interaction, what is order verification, what you can do, what's all this. But I'll show you practically how to do. So you will learn something and you will leave the class. Medication workflow. You are telling right dose, right drug, where it starts. After diagnosis, it starts with prescribing the medicines by a physician. So, at prescribing level, what all the physician will do? He will evaluate the patient, establish need for medicine, select the right medicine, see here, right medicine, determine interactions and allergies, and prescribe the medicine to a patient. When he will be able to determine interactions and allergies? In coordination with a clinical pharmacist where these people perform medication history interview. When you know the old medications, ongoing medications, the previous drug allergies, if anything patient has, food habits, Ayurvedic medicine data, all this is collected, then only someone can determine the interactions. And keeping it in mind, you can prescribe the medications. Okay? Once the medications are prescribed to a patient, next, transcribing or documenting. The nurses will transcribe the medication order in the computer and send it to the pharmacy. After that, the pharmacy will have to double check the prescription order. They'll have to review the order. They'll confirm the transcription. If they didn't understand anything, they can contact the clinical pharmacist or the prescriber directly, and then they can confirm for the dose. If it is a handwritten prescription or if it is a computerized prescription, they can get it out. Now everything is computerized. You order through to the system and then it will reach the pharmacy and the medications are dispensed and got back to the ward. Administration happens with review of the prescriptions after confirm. Once the drugs are received in the wards, they cross check with the patient prescription and then what the medicine they have received from the pharmacy, and then they'll again check it and the nurses will evaluate the patient. Means check all the basics, like blood pressure, if the patient is diabetic, what is the GRBS? Okay, what is the respiratory rate? General examination, general physical examination. Then they will administer the medication to the patient after explaining and then consultation with the clinical pharmacist. And then once the drugs are administered to the patient, you have to assess the patient's response and report and document results. This is what happens from when the patient is diagnosed and then the administration of medicine and monitoring. This is the cycle. What happens with the drugs, okay? Where all the drugs are there, okay? Prescribing, you have drugs. Transcribing, drugs are there. Dispensing drugs, administering drugs, monitoring drugs, everywhere drugs, drugs, drugs. Will play a role in every part of this medication workflow. How will a clinical pharmacist or a pharmacist in the ward play a role? You will understand. So, events in medication workflow, what will happen? Professional practice, doctors, so many healthcare products, so many branded drugs, single agent, many brands. There'll be different procedures and systems. Corporate hospital, different procedure. When a teaching hospital, different procedure. From when the drug is being prescribed till how it is administered to the patient and is monitored. Okay, the process is entirely different. ADRs you monitor, you'll document in a ADR form. That form is same, but how that process happens from the dispensing of drugs, receiving of drugs, every hospital have their own system. Prescribe, order communication, product labeling, packaging, all this varies from hospital to hospital. Nomenclature, compounding, dispensing. So anything that happens, not for a medication, don't say some accident happened to patient. It's not to patient. Drug is dispensed, drug is prescribed, drug is administered, drug is compounded, drug is distributed, drug education happens, monitoring of drug happens. So in this loop only something will happen. Some event will happen. Maybe wrong in prescribing, wrong in dispensing, wrong in preparation, wrong in distribution. Wrong in distribution means instead of sending to one word, they would have sent to other word maybe because of similar names of the patient. Okay? Wrong communication, or because the education was not good to the nurse, confusion between drugs. So anything can happen. with the drug at any level, that will lead to an error or an event. An event is called an error when it will reach the patient. Okay. See what type of errors can happen. Incorrect transcription. If it is verbal order, by the time it is written to paper, you would have heard Lassa drug, similar names, would have heard something. Incorrect transcription, mix up of patients because of distraction, all these things, mix up of drugs, you would have not heard properly. Taking medication orders on the phone, mistakes in calculation of drug concentrations, incorrect labeling, wrong expiry date that would have not been checked, difficulty in handling IV preparation, maybe the technique of using the things, maybe subcutaneous, you've given it IV, incomplete delivery, incorrect infusion rate, absorption of the container, IV sets, wrong, incompatibilities, insufficient mixing of ingredients, not properly mixed, contamination of solution, wrong storage, inappropriate dilutions. So many things. These all are the sources, where how errors can happen. Now, because I am talking about what happens in cancer therapy, what are the medication strategies? Why is it more important to optimize drug therapy in oncology with oncologic drugs? So, because we are dealing with this, I will tell you. See, your goal is to deliver right drug at right dose and proper right dosage form at right time to the right patient. It is the goal. Not only for cancer therapy, for any therapy. So, you need to have your own policies and procedures at every level of medication use process. Medication use process is at prescribing level, verification, that is transcription, again dispensing and administration. At every level, how a medicine to be prescribed, what are the guidelines for prescribing the medications, how we should verify a prescription, what are the checklist, dispensing, what is the procedure for dispensing, how you have to administer, when you have to administer. For everything, there should be a guideline, policy, or procedure that should be defined at your institute or your department where you are working. Okay? Though you should have a practical way to embed all these strategies, create a medication management checklist for the staff, and it has to be completed at every handoff, means at every 8 hours period, every shift they have to have a checklist and they have to give a handover to the next coming clinical pharmacist or a nursing staff. Order, verification, preparation, dispensing, administration, documentation, monitoring, how the waste is disposed. So there should be a checklist on workflow, and it should be audited whether this is being followed continuously or not. Okay? So this should be there in case of oncology. When it comes to handling cytotoxics and targeted agents, so the margin of error when you have checklist policies and procedures that is being followed, maybe the margin of error may be very small. But robust management workflow, medication management workflow should bring people together to process with technology at every step of the medication use process. And it should be double checked and it should be traceable. It should be very easy for people to identify the mistakes. That's how the thing should be defined. Okay, and you have different types of cancer treatment: surgery, radiation, chemotherapy, targeted therapy. And clinical pharmacists play a very important role coordinating the stem cell transplant, CAR T cells, emerging therapies. These all are the emerging therapies. CAR T cell therapy nowadays is become very popular because it's giving life to patients where the cancer is refractory. That's what ma'am was explaining previously. Combination treatments means where the treatment of radiation is combined with chemotherapy and all this. Because these are all why you should monitor, why there is a need of clinical pharmacists in oncology. What is a very much importance? How do they play a very important role? Why optimization matters? Why you need optimization in oncology? What is the reason? Can anybody tell me why optimization is required in oncology? Tell me, guys, why optimization of drugs in oncology? I've told you. Answer me in chat box. I should know whether you are there or not. Why optimization of drugs? Reduce toxicity, personalized therapy to patients. Okay, okay. Oh, yeah. Oh, very good. Very good. Very good. Very good. See, because narrow therapeutic window, even a small change in dose or wrong calculations will lead to severe toxic effects. See, the margin when you take a single paracetamol or 650 mg dose, you are fine. Even to threaten if you take two or three, the maximum defined daily use for every 6 hours you can have your own medication. But if you take this medication of one bottle, for some people it's toxic to liver and you have some antidote to revert it back. So instead of taking 500 mg, if you take 650 mg or a little more up to 1 gram in IV, it's not going to cause you much trouble. But if you take an alprazolam tablet, antipsychotic medication, instead of one pill, if you take two pills, what will happen? What will happen, guys? Abhijit, unmute option will be there. Once I finish my session, we'll switch on the mics and you people can ask me the questions. So don't worry. In between the class, it will be a disturbance. So CNS depression, right? It's very toxic. Yes, correct. That means what? The difference, the therapeutic index is very small. Means even a small change in dose can cause severe toxicities or adverse drug reactions. So all the anti-cancer drugs are narrow therapeutic index drugs. Complex regimens because they contain, like how ma'am was telling me about R-CHOP regimen. I'll show you. What are this complex regimen? How does a chemotherapy protocol look like? Okay, high risk toxicities. They affect the brain, heart, liver, kidneys when given at a wrong dose. And the severity of toxicity will be from grade 3, grade 4, and grade 5. Okay, you have seen CTCAE criteria. So the intensity or the grade of toxicity increases with increase in doses and administering wrong medications to the patient. And drug-drug interactions, individual variability. Every patient cannot tolerate the same dose of medication, like how we were discussing about the CAPOX regimen, CAPOX protocol, and GI cancers. The capecitabine dose in Indian patients is, according to protocol, if you see in guidelines, is 1000 mg per meter square. Okay, but what is given to patients is 850 mg per meter square in Indian settings. And patient safety, cost efficiency. You cannot prescribe, very expensive drugs to the patient because anti-cancer treatments are for longer duration and everybody will not be able to afford for the treatment. Regulatory compliance. So, how you are following the regulations, to handling these medications? All these are very much important. Okay. Now, when we talk about this narrow therapeutic window, these chemotherapy agents, targeted agents, they are very much life-saving at the right dose, but they are very toxic at a little too much. Okay, so precise dosing and monitoring are very much essential. See, when you see complex regimens, one example is they receive multiple drugs, IV, oral, intrathecal, and they have the strict schedules. Even a missed or swapped dose, it will compromise efficacy or trigger severe side effects also. High risk toxicities like neutropenia, cardiotoxicity, hand foot syndrome. So they're very life threatening. And drug interactions because these oncology drugs they sometimes interfere with supportive care medications and patient may be having chronic diseases, like patient may be of comorbidities of DM and hypertension. Those will be when they make a combo of these medications, they may have drug interactions, anti-epileptic medications, anticoagulants, they have drug interactions. So inter-individual variability, what is the inter-individual means in case of genetics, organ function status, performance status, how a patient will metabolize the drug is also very important, based on which the adverse effects depend sometimes. So the dosage adjustments are personalized for every patient. So patient safety, there should be double verification, patient counseling should be there to reduce errors. They have to protect the patient, and to create confidence, trust in the care team. Cost efficiency, you know, accurate dosing and early detection of adverse events. They avoid expensive drugs and unnecessary hospitalizations to the patient. And these hospitals, they should follow the strict guidelines, that NIOSH guidelines, that what I was telling about, how the protocol should be there for handling the hazardous agents, proper managements. All these are very important. So, what are the strategies for this medication management? You have seen what are the reasons for medication management in oncology. What are the strategies? What you can do? Order verification, protocol adherence, independent double check for high risk agents, dispensing under CSTDs, therapeutic drug monitoring. There's so many. Telling a sentence is very easy. How would you appreciate that when you see something and learn how to do? How many of you want it to be something practical and interactive from here? Tell me yes, guys. Just not theory, but you want to see something and learn something. How would you appreciate? With no theory class, and I'll show you something very practical, okay? Yes? Yes? How many number of more? Yes, that many more things you I'll show you in oncology, which has been personally prepared by me. It will be worth it? Yes. How ma'am have been saying that we were a part of care team. How did we work together in different, different levels of care to a patient? I worked with Dr. Krupa Bajaj, and how we have coordinated, how ma'am is appreciating. It's not in her words, how it has been actually been done in the hospital. I'll show you. Okay? I told you, right? The first thing is medication history interview. So everybody will be thinking, okay, I'm practicing in the hospital. Ma'am, I want to go and I just read in clinical forms. I think you'll all find these questions there. how you don't know what to talk to patient, how to talk to patient. You have some, you have something communication skills that should be very good. And you don't know anything, but you have some checklist of what all information that needs to be collected from a patient. Do you think is it easy for you to do that medication history interview? When I give you some form, I'll tell you, guys, I'm giving you some form. Please kindly get all this information from the patient or the patient attender. Would it be easy for you or not? Tell me yes or no. Or if I blindly tell you go and do perform medication history for a patient, is good with a checklist or without a checklist? With checklist, agree? Yes. So it will make your work very easy, right? When you take a printed checklist for some 10-15 patients and you start asking these questions every day to every patient. After doing some 20-25 checklists, checklists and getting the information from the patients, you would understand how the patients are responding to you and what all information you need to collect. After 25th thing, you don't need a checklist. You can go and get all this information very fast. Do you agree? It's making your work easy. You're learning some new skill. Yes. Then see, you try to collect minimum, all this for the patient details to ensure a right prescription. So you understood at prescribing level, your role as a clinical pharmacist, what all you are doing? Yes or no? Do you appreciate at prescribing level? Yes. So at prescribing level, you have to perform a correct medication history interview. See, a normal medication order looks like this. How many of you remember this? Tell me if you remember. Where did you see this? Pharmaceutics, first chapter, prescription, somewhere, parts of a prescription. There is some connection? Yes. So, what are all the parts of a prescription? Date of the prescription, patient demographic, superscription, inscription. So, all this the prescription contains. The same thing is there in even oncology prescription. How the drugs are written here is like this. It does not change date and all this. I will show you how a oncology prescription looks like. Okay. So what I told you, once the prescription is done, verification of the prescription is done by the clinical pharmacist in the ward. Do you agree? Tell me agree if you agree. Agree? Chat box? Agree? Yes, 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 yes. How will you verify an order? On what basis will you verify an order? For medication history interview, you have a checklist. Ma'am, how will I know what should be there in the medication order for a chemotherapy patient? I'm not sure whether this is right or not. So, at your level, at a pharmacist level, to check for an order verification, if you have a checklist, that would be very easy. So, I would show you how it looks. Guys, is it visible, guys? Content
Yes,
of
ma'am, it is visible.
Yes, content of a chemotherapy prescription. See, this is all what we have created from the guidelines for educational purposes, okay? So, when you have a checklist, when I explain you something, when I train you something, guys, these are all the things that you need to check in a chemotherapy prescription. This is how you will have to go and verify a prescription order for chemotherapy. What you'll do? Prescriber's details. whether the doctor's signature is there or not, patient full name, to either unique identifiers, that is ID number or hospital number or date of birth. Because this is very important because patients may have similar names. Diagnosis, whether the diagnosis of the disease is written or not. After seeing all the workup and all what all the tests have done, before the in the prescription, the diagnosis of the patient have to be written. What cancer, what stage. Copy of pathology means stage 1, stage 2, whether it is moderately differentiated. Pathology report will be there. The biopsy report also should be there in your file, the patient file, or at least the written thing. So all this stage of the disease, intentive, curative, non-curative, all this have to be therapy. What is the goal of treatment? Salvage, palliative. You have to see whether it contains this or not. Allergies, if patient allergy, no allergies means no. Any pre-existing medical conditions, whether patient has diabetes, hypertension, concomitant regular medication. The file, patient file should contain all this. Performance status, what is height, weight, chemotherapy protocol, like how ma'am is saying archie. I'll show you what is protocol. What is the date of treatment, duration of treatment, days, dates, frequency, and duration of each. When should be the first drug given, second drug given, multi-day regimens, what that protocol should be there. So you can see all this. Day 1, date, what is the protocol included, what is the cumulative dose, whether it should be written in a generic name, try avoiding brand name, 6 mercaptopurine means sometimes they'll think 5 fluorouracil means some people who don't have knowledge. If you don't have training in oncology and if you're working, some people will think 5 fluorouracil ampules. They'll think it is the dosing instruction. Dose per like what is mg per meter square, or how it is with the target AUC, where carboplatin it is calculated using AUC, cisplatin. So the rounding should be there. All this, it should be nice. So you have some checklist. What is the content of chemotherapy order? How it should be there. You have all this. Means how you should check a chemotherapy prescription. All these points are there. If you keep this in check, that is very easy. Okay. Okay, I'll show you another thing. Stop this here. And then next we'll go for. So after this, guys, this is drug formulary. This is very much important. You should know there are so many oncology drugs. You have to make your own formulary, wherein which, like for every, see abiraterone acetate, albumin, paclitaxel, 5-fluorouracil. What is the dosage form? Which brands are there, in that each brand what dose is available, because when you indent a drug sometimes they may tell you we have 5 flucel 250 mg, they may give oncoflor 500 mg, they may give if the patient requires 750 mg. But you should ensure that the dose of the drug you are indenting, they should contain both 500 and 250 mg, and you should receive the same brand of drug. You should not receive multiple brands, different doses. When you indent a drug, generic name is same, but they have to give you the same brand because the ingredients are different. The compatibilities will change when you get different brands of drugs. So you should have your own formulary and the stocking, everything you need to check. So in the medication use process, when dispensing happens, they have to follow the onco drug formulary. Okay. So this is another way to manage medications and to avoid confusions, because you will be aware of what brands are present in your hospital and you can define your own policies and procedures and drug preparation guidelines in your own hospital. And another thing is adverse drug reaction management. See, you can see the skin and nail changes. This is all what happened. Hand-foot syndrome. It's very much, the patient will have itching, his skin peeling off, so much of darkening. This happens with capecitabine and all this. Okay, in 5 few sometimes. Mainly you will see in capox regimens these things. Oxaliplatin and this tingling sensation, all this will be. So the severity, the grading is very high when this much happens. When little happens, discoloration, that is okay. But when it severely happens, hand-foot syndrome, you will have to consider dosage modification. There will be for every protocol when to consider dosage modifications. Okay. See pedal edema, pitting edema. This mainly you see with docetaxel. So how you have to see, and when related to administration, this is vincristine drug. If you're directly administrating to the patient, it is a drug which will cause extravasation and it may cause, blocking of the veins and infection, very severe. So this is one technique that we have started off. This is called as three-way. Usually, if you directly inject through cannula, you have to, according to the protocols, you have to flush the IV lines with 100 ml saline in a very, fast after administering vincristine. Suppose with injection, they have given vincristine, and in between, because the patient to nurse ratio is very less. Patients are more, administering nurses staff is very less. After you inject, you wait. By the time you connect, you get your NS bottle connected to the, and by the time you connect, in between somebody will call you. You will tell, wait, I'll come and connect, and then the nursing staff will leave. What will happen? There will be a time delay. By the time this drug would have not completely gone inside, because the mg dose for vincristine is a 1 mg, 2 mg maximum depending on the body weight. Hardly 2 mg. Capping dose is 2 mg. So because of that, the drug may get stuck up in the veins here, and then extravasation may develop. So instead of that, you can see here, you will start off giving 100 ml normal saline. After running some 10 to 20 ml from the other side, you start slowly from 1 mg if you mix in 2 ml, and slowly over 2 to 3 minutes, if you push this into this, it is a running flow NS, and you are giving from here and you lock it off and back to back simultaneously, because it's already connected. The NS will, you open completely and give it at a full rate at full speed. So it will wash off the vein. There is no point that the drug will stick there. And you have to keep one slint. When you keep the slint, even when you're administering like 5FU and all, also there will be extravasation. So when you put a slint, when you want to give long infusions to patients, usually the patient's hand will not move. There will be no disturbance to the cannula site. And then the drugs can have easily free flow. Even if patient is sleeping, there will be no harm to the patient at this level. And at monitoring level, how do you monitor? To know that, you need to know few things. Okay? Okay, before we see this, I'll show you something. Okay? Guys, can you see this? Rachna, is this visible?
Yes, ma'am, it is visible.
We were telling about the DLBC. The protocol is like this. This is what we have prepared from the guidelines respect to one of the patient for the patient. See, this is how it contains. What I have shown you one checklist. From the checklist, you can see UMR number, the patient ID, whether the consent is taken or not. What is the name of the patient, age of the patient, date, when it was prescribed to the patient. This will be attached to the patient file. Okay. What is the height? What is the weight? What is the body surface area at the time of prescription? What is the diagnosis? What is the frequency that a patient would be receiving? What is the planned number of cycles? 4 cycles, 6 cycles, or 8 cycles. You can see the pre-medications. After rituximab infusion means first when you are giving R-CHOP protocol, it contains R means rituximab, cyclophosphamide, adriamycin. Okay, vincristin, oncovin, or CHOP. O means oncovin, oncovin means vincristin, etoposide, and prednisolone. So after this, you will give a rituximab infusion. And then, why you are giving evelyn hydrocortisone? To prevent the hypersensitivity reaction, because these MABs are not humanized. See, IMAB, rituximab. The source is murine source. It's a different one. So it has more chances of reaction. And these to prevent vomiting. These are chemotherapeutic drugs. Rituximab is a CD20 antibody targeted therapy. These are chemotherapeutic drugs. So they have more chance of causing vomiting and all this. So you give Akenzio. Akenzio is NK1 antagonist. So how we are treating the patient? So the protocol shows the dose of this drug is this much. You know the patient height and weight. So as a clinical pharmacist, even if the physician writes some dose, you will have to calculate with respect to the patient dose. What is 375 mg per meter square? You have to calculate body surface area using Mosterless formula, and then you have to calculate and then cross check whether this is for one patient that we have written. So you have to cross check whether the given dose, this is called as whether the things are adhering to protocol or not. These all are the protocol doses. These are not given by a physician, but it is given in the NCCN guidelines from where we have taken. From that, NCCN gives you only these things. Rituximab, how much dose, cyclophosphamide, what dose, adriamycin, also. All this you have to prepare by yourself. This we have done. What all given, they will tell you this is the mandatory paracetamol, evil hydrocortisone. But Akenzio, dexamethasone, like whether you want to give Akenzio, whether you want to give ondansetron, depending on the emetogenic potential of the chemotherapy, you will have to decide. This is the brand we use, and so I prepared the protocol like this. So whether there is dosage modification or not. For suppose rituximab, you have to check whether there is. Before this, you will have to check all. See, I'll tell you. And then what is the route? IV infusion or IV bolus or everything. IV. See, this is given. Prednisolone is given per oral from day 2 to day 6. Day 1 means 5 days. Okay, this is given on the day 2. The next day after rituximab infusion. See how you should give rituximab infusion to a patient. You have to start at 25 ml per hour to watch for hypersensitivity reaction for 15 minutes, and then you can increase to 50. You can even start with 10 ml if you think your patient is sensitive and during the first cycle. So all these are there in the protocol. You have to just cross check everything. As a clinical pharmacist, you will have to verify the prescription. See, baseline, you have to check whether the file contains all this test or not. And after every cycle, the patient is coming to receive the treatment, you have to check his CBC, LFT, and RFT. And prednisolone, see here, when to start. This is all is there in the protocol. Some people, most of the institutions in government hospital, they write it off with hand, everything, they'll tell it orally. But as a clinical pharmacist, how do you assist your clinician in making a better place, reduce medication errors and manage medication is after giving the prescription, you have to refer these all things to guidelines. You have to include everything in the protocol, and we have to make a protocol like this. Pextim is because you will have so much of neutropenia with these drugs. You have to give, this is 6 mg subcutaneous 24 hours after chemotherapy. Means first day after giving rituximab, after you finish etoposide, from then 24 hours. After that, you have to give this to a patient so that there will be no neutropenia increase in WBC. Granulocytes. Or you can give GCSF, that is 300 microgram from day 6 till recovery of ANC. Means until the patient, because after this protocol, every alternate day, the patient will have to see for the symptoms, watch for the symptoms. See, and what are the discharge medications that should be given to a patient? A minimum of these medications and like Quicobal strip is vitamin B12 and folate. For 1 month you will give because there are more chances of deficient. Sucralo is for constipation. Sucralo is for good digestion. Cremophene plus is for constipation. See, if patient, you will have to counsel on the drugs after chemotherapy. What are the supportive medications the patient have to take to prevent these adverse drug reactions, and how you have to some patients may have additional things also, so you have to perform medication reconciliation and add on these drugs. So every cycle, why we are monitoring the patient cycle 1, cycle 2, cycle 3 is cycle 1 patient dose you are writing here. So the same thing will be for cycle 1. For cycle 2, if there is any weight loss because of any adverse effects, see, you are checking for dosage modifications depending on organ function status. So if any change in dose, you'll write here. So you will understand, you will have to record why this dose was changed. You have to document. See, all these things you have to note down minimum for just for renal performance. RFT you have to see, LFTs you have to see, CBC you have to see. At least these things you have to record for every cycle, and then you have to write what are the adverse effects faced by the patient. Suppose when you have to change the dose of vincristine, grade 1, these grades are CTCAE grades. So how you will know which is grade 1, grade 2, grade 3? You have something defined there in CTCAE. You can go and download CTCAE version 5. You will see for every toxicity, organ toxicity, what is grade 1, what are the symptoms? What is grade 2, what are the symptoms? Grade 3, what are the symptoms? And grade 4, what are the symptoms? Okay? Based on that, you can understand what is grade 1, grade 2, grade 3. See, nadir means, if ANC means, is like this. What is the ANC means absolute neutrophil count. Suppose your WBC is 4,000. Neutrophils are 70%. So 70 of 3,000 is your absolute neutrophil count. So you will understand whether it is greater than 1,500 or not, and then whether you can give chemotherapy or you will have to wait, or you, that is why you are giving Pextim or Pegfilgrastim. So for doxorubicin, renal impairment, liver impairment, what is the doses? That is why you monitor the organ function status. Why you are monitoring organ? Liver is the one which will metabolize drugs, and kidneys are the one which will eliminate. So when you're taking toxic drugs, your function of liver should be very good, and your renal system also should be very good to filter out the drugs, so that the patient's treatment will go very smoothly. So in case of adverse drug reactions, what should be monitored? You can see here R is in capital letter, I, TU is in capital letter, X is in capital letter. Did I write it wrong, or it is like this itself? Guys, did you observe this? Why did ma'am write like that? Why did I write like that? Why did I prepare like that? Can anybody tell me what it is? Anybody? She doesn't know how to write English, right? Can you tell me? Very good, Abhijit. It's Stallman lettering to avoid, Lassa drugs. Yes, very good. Very good. So you understood when I'm making protocol, what all I have taken care of. This is called as protocol. So verification of chemotherapy against a standard protocol is you have a checklist and you are seeing all this. If you want, I'll show you one checklist which I have made. Once again. See, guys, is it visible?
Yes, ma'am, it is seen.
See, this is one checklist for chemotherapy which are prepared to whom? Make the process easy. See, when I will send some student in the ward and ask them to go and check a chemotherapy order. That is protocol. I will tell you how the chemotherapy order looks like. See, check against all these things. Whether these all are present in the prescription written or not. Okay, this is one checklist. Go to every patient. I give them this checklist. Again, 10 patients per each day. They go and check whether all these are present or not. Does it make your work easier or not? Tell me, guys. Yes, right? I'll tell you. Go and audit. Prescription audit. Have you heard of this word? Prescription audit. Ma'am, date is present, dose is present. Prescription audit. Heard of? So, this is for a chemotherapy. This is something called like a prescription order. Means prescription audit. Shaheen, you're asking me if every oncos have same checklist pattern. See, it's not every oncology prescription need to have this. This is not something made by me, but these are from the guidelines. These are taken from the standard. The standard says there's so many guidelines, and the standard says this should contain all this. So these are mandatory in a policy. From the policy, after designing the policy, I have taken those components. I have prepared a checklist. I will show you how you have, please guys, if you want, you can take the photo of this. I will show you now chemotherapy order. You can cross check whether everything is there or not. Then you will better understand. Agree with me? If you agree with me, please take a photograph. I don't have any problem. You take these components. I will show you. Then you can do the prescription audit here. It will be more interesting. See, take a photo here. I'll go down. Take the remaining things. Take the screenshot. Do this. Are you done? Shall I open the chemotherapy order sheet? If you tell yes in the chat box, I'll do it. Okay. Now see whether everything is there here or not. Just check patient name is there or not. Is it visible, Rachna, that thing?
Yes, ma'am, it is visible.
Okay, just check in the prescription whether patient name, age, means the space for age, height, weight, BSA, diagnosis, protocol name, cycle number, when the date should be given, directions, duration of infusion, diluents, volume, everything is there or not. I don't know what happened. I'm not able to see this. One second, I'll share it again. See guys, patient name, IP number, BSC, height, weight, cycle number, diagnosis, protocol or drugs, what is the ward, date, when the corresponding date should be given, hematogenic risk, what is the drug name, protocol dose, what is the patient dose, what is the route, what is the volume, diluent, duration, start name, signature, double signature, means nurses administering two people should cross check. See, other drugs that need to be administered. What is the signature of the consultant, clinical pharmacist? So this when chemotherapy order sheet means you have seen the protocol. So now you have seen in the protocol. Here, drug name, protocol dose, patient dose. For every cycle, when patient comes, you need a prescription. In protocol, when the patient's treatment decision is taken, everything is present. Now, what you will do? See here. So, when in the drugs column, you people will be writing like this. Rituximab, patient dose is, protocol dose is 375 mg per meter square. Patient dose, route, volume for hours, day one. That all will be there in the chemotherapy order for every cycle. You'll write the list of all these drugs. Sequence means after rituximab, cyclophosphamide should be given. After that, adbriamycin should be given. Vincristine should be given. Etoposide should be given. Whether this order is written correctly or not against the protocol in every chemotherapy order, because why you are writing chemotherapy order is sometimes in some institutions they fill the dose here itself, but in almost this is a protocol, that is this decision of the patient's treatment is attached in the patient's file. But every cycle the weight keeps changing, things keep changing, you can't write here. So that's why there'll be chemotherapy order sheet where based on every cycle the prognosis of the patient, outcome of the patient, whether drugs are continued or drugs are stopped for any reason, every time it will be filled in the order sheet. And during the discharge, in discharge summary, you will be having the discharge medication if anything is extra added. Are you clear with this, guys? You have understood this? Yes or no? Yes, that is why, that's what I showed you, Soundarya, when it is vesicant and all. I told you how we are giving vincristine drug for administration. Drugs, okay. Want to see this? See, somebody wanted to see this. You can see this. I'll show you some other things. Okay. Now I'll share you the PPT. So you have understood this. And guys, at anywhere in the medication use process, errors can happen in oncology. Once error happen, okay, before we discuss something about errors, I would show you something. See, you can see here like L-asparginase, PEG-asparginase, PEG-L-asparginase. PEG-asparginase and PEG-L-asparginase are same. But L-asparginase is entirely different from PEG-L-asparginase. The doses are also different. The indications are also different. Okay? When you're giving it for a patient. If you don't know how to differentiate between these two drugs, it will really cause death to a patient. Okay? Such errors usually happen. Vincristine, vinblastine. And you know how to, which I was telling about grade 1, grade 2, grade 3, grade. In case of nausea, if patient complains these are grade 1. If this one, grade 2. Grade 3, if these are the symptoms. So this is how it is. So for every adverse event, there are grades. You can go here and download the PDF online. Okay. This is some few things which I wanted to show. And this is how you have to monitor an adverse drug reactions. You have to completely take the details and fill them. And do you have any question? I'll show you something called as how do you go and play a very important role in oncology, counseling the patients, like chemotherapy consent. form. Okay, I'll show you that if you are interested to know. I'll share you that thing. Stop here and then you can see this. This is also that I've prepared a consent form in English and Telugu. These are also taken from guidelines, and then we have written every point myself. See, I was telling you whether what is the intent of chemotherapy. It shows here curative, adjuvant, neoadjuvant, palliative, salvage. You have to. They have the physicians will tick it. So when you are explaining, you will teach everything to the patient. What adverse effects will come? How do you give chemotherapy? Like whether you are giving it through that a venipuncture will be there. You put a needle into a vein, remove the blood, administer chemotherapy. Sometimes you are keeping any ports. That all you explain. What adverse effects will not. What you do. What the long term effects all this physician will explain, but even in the ward, when the patient comes, will explain everything. Anti-sickness medications to see in supportive care medications, you will have medication like sucralose syrup I told showed you for digestion, all cremafen for constipation. So all these are related to this anti-sickness. So this all will be there like growth factors using PEG-CSF injections that you will be given. So when you give that, what kind of adverse effects you will get. So you need not worry. All these things you will explain to the patient and they will take the consent for chemotherapy. Every point is written here. This is like concisely prepared by us in the department. Okay. Guys, this is one more thing I have wanted to show. I showed you. Guys, now if you want to know or you have any questions, you can ask me. In this ample amount of time, I think I have covered maximum. And if you would like to know anything, and you can ask me, guys. Maybe in regular classes, you would have seen me discussing so many live examples, but I could show you the whole process and what happens in a department. And there have been policies that have been made by us, and I coordinated some bone marrow transplant and all the transplants and CAR T cell therapies which have been a part of are successful. And I'm very happy to share that. Hope, guys, did you learn something from here? I'll be very happy to see your feedbacks in the chat box. Have you learned something? Have you seen something real? Contents of chemotherapy which you had done. Yeah, surely I'll do it. Uh, Ma'am, how to calculate carboplatin dose by using AUC? Tanmay, I will tell you how to calculate. There's a formula to calculate a carboplatin dose, but before that, please go and check any protocol, how it is written AUC 5, AUC 2, AUC 6, like that, it will be there. Okay. So I'll show you the guideline and formula how to calculate the AUC dose. For that, you need to have GFR also. So dose of carboplatin is equal to AUC into in brackets GFR plus 25. So that AUC is that you don't put a graph and do it. You will have that number AUC 2, 5 or 6 or 7. Okay. You can just check it in the protocol. The formula is that. If you want to see, I will show you the formula also once again. How it is. Somebody want to see this. I'll show you 1 second. Guys, is it visible? This is the formula. And something I would like to show you something, some compatibility charts that I have found. That you were asking me what we have even done these things. Like I was telling you about formulary adherence and what are the drugs. So these are the drugs which were commonly used in the hospital because targeted therapy drugs were not used in the teaching hospital. So insulin is a very commonly used drugs. So from that, by checking out every drug, I have prepared the reconstitution. What is the compatibility, whether it is NS or dextrose, what is the volume of dilute, what is the concentration ranges that you can prepare these drugs, what are the special precautions. These are few charts which I have made it based on the formulary. Okay. To ease the process to reduce the medication errors, even if nursing staff doesn't know, they can refer to these common drugs and they can do it. If they used to have any doubts, says to give me a call. So this is one more thing that which I have prepared. And I can even guide you like how to make these charts in your own hospital setup. This is what we train in our oncology course.
Ma'am, there are a few questions. Would you like to
Yes.
read it for you?
Yes, kindly. Very happy to
Navya,
listen.
yes, ma'am. Navya is asking, could you please mention the standard protocol you referred?
Could you mention the standard protocol you referred? Ma'am, I have Archer protocol is a standard protocol. Go to NCCN guide. If you have any doubts, you just go browse through NCCN guidelines. The NCCN guidelines shows you the doses of the drugs. And for every chemotherapeutic drug, you need to give a pre-medication and you need to give a supportive care medication. Pre-medications, they will tell you give a anti-emetic regimen. So that regimen we will have to decide for the patient. I told Akenjo cost around 6,000 rupees and it is NK1 antagonist. You have a normal ondansetron also. So you have some anti-emetic regimens. If it is highly emetogenic, means if the drug has higher potency to cause vomiting, you will have to stop vomiting level at your vomiting center. So you give NK1 antagonist. If it is very mild emetogenic potential, you need to, depending on the drug characteristics, you will have to give to a patient normal ondansetron that you're giving it for 5 days in your supportive care medication to prevent vomiting. That can be given. Some protocols don't require anti-emetic regimen because the chemotherapeutic drugs don't have that. Those things we have did it by ourselves. Pre-medications and supportive care medication because depending on the protocol, the guidelines will tell you. The brands and that all you will have to choose. But that rituximab ka dose, that standard doses are there in the guidelines. From that guidelines, we have prepared these protocols. Okay, Navya? Any other question?
Ma'am, Praveen is asking if you can kindly share the PPTs and forms.
Forms I cannot share you because those are protocols that we have customized for patients. If you want to know, check for different protocols, you can refer BC Cancer and all. Because these are hospital documents, it's taken a lot of time to do. I can only guide you. I can tell you where are the standards. From the standards, you will have to prepare your own. We should not share this to everyone. as per the policies, but I have shown you because when ma'am was discussing that we have done it in a team to show you how a clinical pharmacist will be in a healthcare team, why an oncologist will encourage you as a part of healthcare team. I've shown you what we have done all this. We only guide you to do all this. The standards, everything is there in BC Cancer. You have some ASCO guidelines. So you have to read hundreds of pages to make your own document. And those are made with respect to the hospital policies. If you want, I can show you the policy also from the standards how I have written. But we cannot share those documents.
Yes, ma'am. And we have a question from Dr. Sauhardya. Ma'am, how do we
Mm.
analyze medication errors after root cause analysis?
Okay, I'll tell an example. Okay, well, I'll show you that one also. Wait, I think that was there in the last slide. One second. See, first you have to realize the problem. Root cause analysis process. I will tell you with one example. Suppose you see bleomycin. Bleomycin for the drugs when they give in BP regimen and all, they'll tell you to give it in subcutaneous form. But there are different brands of drugs. Some brands can be given as, like only subcutaneous. Some drug have to given as IV. The prescription says give bleomycin 2 mg subcutaneous. But the brand that the pharmacy dispenses to you, because pharmacy will only see the indent of drug as bleomycin. Pharmacy will not know which route of administration the physician has prescribed. Usually bleomycin is given as subcutaneous. But the formulation that is available in your hospital or brand shows given it as IV. So you will have to check whether the drug is meant for IV administration and subcutaneous administration or not. If it is meant for both, you can give it as subcutaneous. If that vial says only for IV administration, you will have to give it only IV. Now you got some error and they have given it off in subcutaneous or instead of subcutaneous. If it contains both subcutaneous and IV, you can give it as IV also, you can give subcutaneous also, no problem. But if it is meant for only like prescription says subcutaneous, if the drug is meant for IV, you cannot give subcutaneous. Okay? So you have given it. So you have to realize the problem, where the problem has happened. So what you will have to do when you're verifying a prescription, you have to check that also. What is the route of intended route of administration for a patient and what you have received the drug formulation. So during verifying prescription, not only the prescription that you will verify doses, you have to verify what drugs you have reached in the ward also. If you could not identify at that stage, why? What is the commonly given? Then you have to call the physician and inform. Ma'am, you have given subcutaneous in the prescription, but the vial available in the pharmacy is IV route, and we are doing this and we are changing this. And you have to give it. What is the causal factors? Means the formulary adherence is not there. So you have to ensure while checking the brands. Even for methotrexate, you give it as IV, you give it as intrathecal, you give it in different routes. So you have to check whether the vial is meant for, even in Google image, you can check whether the route it is meant for IT route, IM route, IV route, and what is the route given. So you have to identify the root cause. Why that error had happened, the dispensing had happened wrong. No, it's not the mistake of dispensing. After receiving, the nurse would have not cross checked what is the prescription medicine and what is the intended drug route that was dispensed. Or the clinical pharmacist, when they're preparing the drugs, you should check it. Okay, whether it is written correctly or not. And then you will have to tell from after you analyze this problem, root cause. What is the root cause? Why the error has happened? You have to check it, and then you'll have to educate and you have to correct it, the prescription, and you have to make the formulary changes during your the pharmacy and therapeutic committee meetings. First, you will get a medication error and then you will analyze why it had happened. Okay, Saundarya, did you understand, Sandra? Renuka, as simple as this, I'll tell you, don't go for any guidelines. Check for the patient information leaflets that are provided with the drugs for dilutions. Okay, and patient characteristics. If it is, you have to see concentration range and give it at a minimal volume for people who are renal compromised, and you can extend the volumes for people who are very normal. Ma'am, but when I did use the Medscape calculator, those came back 42 kmg by you. That's okay, 420 mg. That's fine. It can come anything. 420 mg, 700 mg, 900 mg. Go to NCCN guidelines, check for capping of carboplatin dose. If it comes more than 900, you should not give 900. Maximum you can give is 900 mg. That is called as capping. Tanmay, did you understand?
Ma'am, that is 42,000 mg.
It is not 42,000 mg. It will come 420 mg.
Yeah, that he has mentioned that it is 42K, so 42,000 mg.
No, 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 no. You just check it properly. You have to put the parameters correct. Check the units what you would have typed. Serum creatinine value. All this. Check the units once. Height, weight in centimeter, weight in kg or pounds, what you have typed. Check it. If you have doubt, do it in the formula which I have told you, you will get it correct. AUC into, in brackets, GFR plus 25, glomerular filtration rate to be calculated based on Cockcroft-Gault formula. You will get some value of GFR. GFR plus 25 you will have to add, then multiply with AUC. Okay. Atropine, it is given as pre-medication, and then even in discharge medications, you will have to give medications and also counsel patients regarding the loose stools, okay? Everybody you will have to give as a part of protocol atropine. As a pre-medication, you have to give to every patient, that is mandatory. Contents of chemotherapy, chemotherapy protocol, I will surely share it, don't worry. It's even there in the guidelines. Yes, ma'am, I'll try again. If problem persists, I'll ask you tomorrow. No problem, Tanmay. I am always there till the last day. You can ask me anytime. You can even message me on LinkedIn if you get it out. Don't have any problem. Guys, if you learn something and today shall we turn off? Or you have any other doubts? Tell me yes, guys, or no. Something you have learnt of today? Is oncology interesting? Okay, guys, if you have would learn something, you can post on LinkedIn your learnings. Okay, good night. Take care.
Thank you, ma'am. Thank you for that highly informative and essential session. Your emphasis on safe handling practices is truly valuable for all of us who want to work closely with chemotherapy agents. Thank you so much once again, ma'am. As we wrap up the day 3 of Oncology Pharmacy Conclave 2025, I extend a heartfelt thanks to our esteemed speakers, Dr. Kripa Bajaj and Dr. Prabalika Utukuru, for sharing the knowledge and expertise with us. So please fill the feedback form before you leave. And a very big thank you to all of our participants for your engagement, enthusiasm, and commitment to learning. We look forward to have you all back at 7 p.m. tomorrow evening. Until then, stay inspired, stay curious, and keep advancing the science and soul of oncology practice. Good night, and thank you for being with us today.